first thing I'm going to do when I arrive on scene is make sure that I'm wearing my BSI, my gloves. I'm going to look around to see if there are any potential hazards. I do not see any potentially threatening people, any downed wires, any hazardous materials. My impression is that this scene is safe. I'm going to approach the patient. I'm noticing that there's only one patient on scene. I'm going to form a general impression of this patient. This patient appears to be a 30-year-old male who appears to have suffered trauma as a result of what I'm going to say is a car accident. The first thing I'm going to do now as I approach the patient, and I'm going to have my partner stabilize the patient's C-spine by holding the head. I am going to determine this patient's level of responsiveness. As I approach this patient, I say, hello, hello. This patient does not appear to be alert, and they are unresponsive to my verbal stimulus. Hello, not getting anything. Now I'm going to pinch the patient's clavicle. They are not responsive to pain, so neither responsive to, neither alert, nor responsive to verbal, nor to pain. This patient is unresponsive. I am going to check this patient's airway using a modified jaw thrust technique. I'm going to visually inspect the airway. If there's anything in the airway, I'm going to use suction or clear anything out of the airway that I need to. Then I'm going to assess once the patient's airway is patent, once it is secured. I am going to assess the patient's breathing. I'm going to look, listen, and feel, listening and feeling for breath. I'm also going to watch the chest rise and fall. I'm going to note the number of breaths per minute and the quality of respiration, whether it is shallow or deep, whether it is easy or labored. Now I'm going to check the patient's circulation. I'm going to first take the carotid pulse, checking whether or not the patient has a pulse, how many beats per minute that pulse is, and the quality of that pulse. Is it thready? Is it strong? Is it bounding? Is it weak? I'm going to also check the patient's distal pulse, asking the same questions, beats per minute, and what is the quality of that pulse. Now that I've checked airway, breathing, and circulation, I'm going to do a quick body sweep for blood. So beginning at the head where my partner is holding C-spine, I'm going to sweep through every part of the body, the shoulders, checking my gloves for blood as I go. Checking the legs, checking for blood. And checking the arms. And the last thing that I'm going to assess is the skin color, temperature, and appearance. And finally, I'm going to say that this is a high priority patient. This patient is unresponsive, appears to have been in a car accident, may have suffered trauma. So we are going to transport this patient rapidly. To do that, we're going to move down to the primary assessment. We want to get them onto a backboard. So I am going to roll this patient over. As I do that, I'm going to visually inspect the patient's posterior. My partner is going to bring the backboard. We're going to roll them back down onto the backboard. And now we're going to get this patient into the ambulance so we can move. At this time, I'm going to begin my primary assessment of this patient. So I'm going to, again, begin at the head. I'm going to have, beginning at the head, I'm going to palpate the head, checking for any decap, BTLS. Moving down the head to the neck. At this time, we're going to check for any JVD or tracheal dissension, tracheal deviation rather. I'm going to have my partner help me put a collar on this patient. And we are going to continue to move down the body. At this time, checking the shoulders. At this point, I'm going to cut any clothing off of the patient so that I can have full access to the patient's body. Moving down their body, I'm going to palpate the ribs and palpate the sternum. I'm also going to use my stethoscope to listen to both of the anterior sides of the chest. What I'm listening for is paradoxical respiration. At this time, I'm going to say that respiration on both sides of the chest is normal. Moving down the body, I'm going to palpate all 4 quadrants of the abdomen. I'm going to again check the pelvis. I'm going to move in a more thorough and focused manner down the legs. And at this time, I would remove the patient's shoes if they were wearing them. I would check circulation, sensation, and motion on the feet, and also check capillary refill on the feet. And I would also, again, check distal pulse. I would come and do the same for the arms, doing a more focused assessment of the arms, checking capillary refill on the fingernail beds, checking circulation, sensation, and motion in the fingers, and also, again, checking distal pulse. I would be recording the pulse. This would be my first set of vital signs along with the patient's breathing rate. Those are the vital signs that I've taken so far. Having now done the primary assessment, I'm going to move into performing the secondary assessment and more focused assessment of the patient's body. So again, starting at the head, I am going to do a visual inspection of the face. I'm going to palpate the head. I'm going to check the patient's orbitals. I'm going to check the nose, check the mandible. I'm going to use my light and look at each of the patient's eyes, see if they're equal and reactive to light. At this time, I'm going to say that the patient's pupils are equal and reactive to light. I'm going to check behind the patient's ears for battle signs, signs of blood pooling. I'm also going to look in the ears for any cerebral fluid pooling. Again, I'm going to check the neck for any signs of JVD that I may have missed. Moving down the body, again, I'm going to palpate the ribs. And at this time, I'm going to use my stethoscope and I'm going to listen to both anterior and both posterior sides of the chest. Moving further down the body, I'm once again going to palpate the abdomen. I am going to move again down the legs, doing a more focused assessment. At this time, I would once again check distal pulse on each of the legs, check capillary refill in the nail beds, and if the patient were awake at this point, if they were to regain consciousness, I might have them push up on my feet, up on my hands rather, I might have them push back on my hand to check range of motion. And I would also be asking them, can you feel, as I'm testing for circulation, sensation, and motion in the feet. I would do the same on the other leg, having them push up and push back. Moving up to the arms, I'm doing a focused assessment of the arms, checking capillary refill in the nail bed, having the patient, again, if they're conscious, squeeze my finger, test responsiveness there. At this point, I would also take the patient's blood pressure and have it recorded, doing the same for the other arm, checking circulation, sensation, and motion, checking distal pulse. At this time, I would also roll the patient again and do a more focused spinal assessment, palpating the spine, looking for any signs of deformity, any crepitus in the spine, looking for anything else I may have missed on the posterior side of the patient, and rolling them back down. At this time, I would make sure that my first set of vital signs was recorded. 5 minutes from now, I would reassess this patient. Also, if this patient were to regain consciousness, or if there were to be a family member, somebody who knew the patient well in the ambulance with me, I would ask for a sample history, so asking for signs and symptoms of what happened, any allergies or medications, any allergies the patient had, any medications they were taking, the last thing that patient ate, and anything about the events leading up to the injury. Then we would continue to reassess this patient every 5 minutes, taking a new set of vital signs every 5 minutes on the